start the recording. So again, if you want to let us know where you are from in the chat, please do so. So I want to welcome everybody to our session on insights for scoliosis management and surgical options for Marfan syndrome. I'm Dr. Josephine Grima. I'm the Chief Science Officer for the Foundation. I'm delighted to introduce you to Dr. Paul Sponseller. Dr. Sponseller is a professor of orthopedic surgery at Johns Hopkins School of Medicine. His areas of clinical expertise include pediatric spine disorders, cerebral palsy, clubfoot, hip dislocations, and hip dysplasia. He is a longtime member of the Marfan Foundation's Professional Advisory Board, and many of you have probably met him during our conferences each year. So during the presentation, if you have questions for Dr. Sponseller, please use the Q&A option at the bottom of your screen. If your questions cannot be addressed during this Q&A time on this webinar, please put them at, please go to our website at marfan.org/ask, and we can really try to get those answered at a later date. So right now, I'd like to welcome Dr. Sponseller to share his screen with us. There it is.
Is it in presentation mode?
It is in presentation mode, and it looks perfect.
Okay, great. Thank you.
If you want to, go ahead. If your video is off, but that's fine. We can turn it on later.
Good afternoon, everyone. Thanks for letting me talk to you about one of my main interests professionally, which is keeping the spine healthy in children and adults with Marfan syndrome. We'll talk about spinal issues, including scoliosis, kyphosis, and spondylolisthesis. We'll talk about dural ectasia, which is like an aneurysm of the dura, and we'll talk about back pain and its various causes and how to help it. So one of the main health concerns in Marfan syndrome is various spine problems, including scoliosis, fatigue, and kyphosis. We need further research on these because many of them are still works in progress. In the spine, you can have an increased frequency of these conditions in Marfan syndrome because of how the growth of the skeleton is not well regulated. You can have scoliosis, which is a curvature that you look from the front, kyphosis, which is a curvature when you look from the side, and slipping of the vertebrae, either forward or backward, called spondylolisthesis. We'll show you examples of each of these. So scoliosis and Marfan syndrome can be mild at the start, but it can actually get significantly worse as you go. Look at the difference between this patient who is 10 and then 3 years later at age 13, the curve had gotten significantly worse. About 2 out of 3 Marfan patients have scoliosis. It doesn't always worsen, but it often does worsen. Only about 10% of them, however, need to either wear a brace or have surgery. With Marfan syndrome, the curves will increase faster, and there's an increased risk of back pain compared to non-Marfan people. So we usually like to try to prevent these curves from getting worse. And the usual tool for that is a brace for spine. Does a brace help to straighten the curve? No, it doesn't, unfortunately. It just holds it where it is. But the results of bracing in Marfan syndrome are significantly less good than idiopathic patients. Only about 20% of patients will have their curve stabilized with Marfan syndrome. 80% will see the curve worsen, and some of them will need surgery. Part of the reason the bracing doesn't work is just the shape of the body and the shape of the ribs being so sharp and pushing hard on the brace and being intolerant of pressure. And also in the front of the spine, you can have pectus excavatum or carinatum, which can cause pressure on the brace too and be very uncomfortable. So what I like to recommend is starting bracing at an earlier point. Instead of the typical 25-degree threshold, I usually like to start at 15 or 20 degrees in young children. But I also avoid putting braces on people who it's really not going to help. If it's too late for a brace, such as a bigger curve and a kid who is just unable to wear it or is not willing to wear it, that's probably something you should recognize as a losing battle and avoid getting into it. A special kind of Marfan syndrome is the infantile patient, those patients who have severe curves before the age of 3. They often end up needing surgery before the age of 9. And surgery tends to arrest trunk growth. A traditional spine fusion stops the growth of your trunk. So we like to try to maximize the growth of the spine for body health and respiratory health. So in those patients, we use a growing rod, which is like an internal brace that still grows with you. Here's an example of a child who's just not even 3 years old. You can see how sharp her lower curve is, how bony she is, and she was not able to wear a brace comfortably, so she had to give up on bracing. We did a growing rod in her, and you can see how with 2 small incisions, it allows the trunk to be much straighter and stable and doesn't need a brace. These are her x-rays to the left on the top, to the right on the top. You can see the severe curve and the two rods which are inside, and they function as internal braces. And those rectangular blocks at the top are where we lengthen the spine from. And we lengthen it a little bit every year so it'll grow taller with the patient. And that in turn controls the curve by stretching out the spine. We studied the results of growing rods in Marfan syndrome, and they're really quite good. Patients with Marfan syndrome have flexible spines and they're elastic, so they can get quite a bit of correction with the rods, and they can continue to grow for a good long time compared to non-Marfan patients. And these patients got an average of 4 inches in length over just 5 years, and none of them had any infections. This diagram on the right is what a growing rod system looks like. The rods are placed underneath the muscles up against the spine, and they're attached to the spine at the top and the bottom with hooks or screws so that they anchor to the spine and stay there. And they control the spine and push it upward in a straight fashion instead of letting it be loose and curve sideways. Recently, in the past 5 years, instead of having to do repeat surgery to lengthen the rods, we've been fortunate to see the development of a magnetic rod lengthener that's able to be lengthened outside the body by the use of rotating magnets. It's called a magic rod. And this is a little girl on her side showing how she is getting her rod lengthened right there in the office with her mom holding her hand. Because it's magnetic, it can't be done if the person needs to have frequent MRIs to check their aorta or to check any other medical problem that might be going on inside their body. But as long as they don't need that, then they would be good candidates for a magnetic growing rod. You can get similar degrees of length from the use of the rod. Some patients need to have fusion of their spine, and that's a typical thing that you may have heard of. And we studied the results of fusion in Marfan patients, comparing them to non-Marfan patients who we call idiopathic scoliosis. We did a 2-to-1 matching of Marfans to idiopathic patients. So we had 34 Marfans compared to 68 idiopathic patients, because there are so many idiopathic patients that need surgery in the population. And what we found was quite interesting. The Marfan patients had more complicated courses. They had more displacements of the rod. They had more surgical reoperations. They even had more spinal fluid leakage called CSF leaks, because the spinal fluid in Marfan is under such a thin covering of dura. It's more prone to leaking. And they had to have more areas that we had to go back and fuse above and below unfused thoracic and lumbar curves So you can't fuse just a short area of the spine in Marfan syndrome. You have to fuse a longer area, because if you ignore some areas, they will often keep curving as the person grows. Slippage of the vertebrae is called spondylolisthesis. It's a Greek word because spiny means spine and listhesis means slippage. It's more common in Marfan syndrome because of the laxity of their tissues and the laxity of the discs. Here's an example of a spine. You can obviously see how the vertebrae are rectangles stacked on top of each other. And here you can see one of them is slid forward on the other significantly. And so this is fixed by surgically linking the two together and fusing them so they can't keep slipping. This can be a painful process, but it's rarely neurologically compromising because the nerves adapt to the slippage over time and they stretch out. One of the things that you have to be aware of and deal with in Marfan syndrome is the differences in your bone. The bone is very thin in certain critical areas, like the pedicles where we put screws and the lamina where we put hooks. You can see here how thin these areas are where the red arrows are. Normally they're about 2 or 3 times that thick, but in Marfan persons, typically they're very thin and harder to put a screw in and keep it there. The vertebrae are also scalloped by the dural ectasia, meaning there's less bone to fix to. More on dural ectasia. This is present in over half of Marfan patients. Same thing in Loeys-Dietz syndrome and Ehlers-Danlos syndrome. What is it exactly? It's a dura that gets larger and wider as you go down the spine. From the sacrum, from the 4th lumbar vertebra to the sacrum, it gets wider as opposed to it normally getting narrower. Some people even have a telltale sign of an anterior meningocele, which is a sac of fluid that dissects outside the spine and goes into the pelvis, where there's resistance to it. And dura is typically a tube that protects the spinal cord, just like the aorta is a tube that controls and conducts your blood. It's a very analogous phenomenon in Marfan people. So you can see here on the MRI on the right, you can see how the vertebrae are scalloped by the presence of the dural ectasia. The discs don't get scalloped, but the bones get scalloped. How does dural ectasia develop? We think it develops because of spinal fluid pulsations against the bone. And that in turn dilates the weak dura, and that erodes the vertebral body. There may also, however, be signaling effects with TGF-beta being present on the surface of the dura and leading to more reabsorption of the bone and thinning of the pedicles and so forth. Does dural ectasia cause pain? Not always. We did a case control study of people in the middle ages of adulthood. The dural ectasia group had more pain, but not all the dural ectasia patients had pain. There were some, even with the pronounced dural ectasia, like you see on the right, that had no pain whatsoever. So we don't know why some do and some don't, but it probably has to do with whether the dural ectasia is putting pressure on your bone or pressure on your nerves or kinking and twisting up the nerve roots into the dural sac. What you do about it is still a work in progress. We tend to patch up areas that are ballooning out and shunt it to other places when needed. But we wish there was a better biological solution. The symptoms associated with dural ectasia include pain in the very low part of the back, right down to the sacrum, not in the middle of the back. Also, headaches are seen in many people with dural ectasia. And we think that's because with dural ectasia, there's a lot more spinal fluids shifting up and down, and that can create a draining pressure on the brain and the dura of the brain. Also, they can have leg pain like you would with this herniated disc or sciatica. And even they can typically have pelvic pain and perineal pain in the area of the rectum and the perineal area, where dural ectasia is more pronounced. Does it get worse? Many people wonder whether they should do something about it. Well, it's small because it will get worse. The answer is it doesn't always get worse. We did a 12-year follow-up of patients with dural ectasia and got a repeat MRI and found that, in fact, severe dural ectasia does not always get worse. It depends on how old you are. The ones that got worse are mainly over the age of 5. Here's an example of a 48-year-old male with moderate dural ectasia in 1998. And 11 years later, you can see the dural ectasia is essentially about the same size. So we actually did a statistical analysis of this group. We found that the volume of the dura from one period in 2008 to the later period in 2009, the calculated volume of the dura was not actually any greater in the later group than the earlier group. What about back pain? Back pain is seen in a lot of people with Marfan syndrome. It can be caused by scoliosis. It can be caused by kyphosis. It can be caused by slippage of the vertebrae, or even possibly by dural ectasia. And things that usually work are non-surgical things, such as physical therapy, core strengthening, conditioning, Pilates, and also a brace at times can be useful. However, there is a last resort for many people, which is spinal cord stimulation. And that's something that actually deals with chronic axial or back pain. It works on the gate theory of pain, that by stimulating the pain fibers, you can inhibit the travel of painful fibers. And so that's a way to.
Can you see if you can? I think your slide is not advancing. I'm still seeing the dural ectasia slide.
Okay. Here it is. I'm sorry.
Okay. Yes. Thank you.
What the thing does is it puts signals in the back part where the sensory fibers go in, and that blocks the fibers from traveling down the spinal cord. It confuses the pain signaling pathway and basically blocks it. And here's what it looks like applied to a person. Let me see if I can find it. I had a slide of it on there, but it's like a metallic disc, and it's attached to wires, and the wires are inserted onto the top of the spinal structures. It's a minor surgical procedure, not a large open surgical procedure. It's pretty minimally invasive, and it's typically done by a pain treatment specialist. If you have a pain treatment center available to you, they can often discuss the pros and cons of spinal cord stimulator with you. It's good for mostly axial pain, although it can help with other kinds of pain. I've seen some patients with Marfan syndrome who had intractable pain and were helped by the presence of the spinal cord stimulation. So I think we talked about deformity and why it gets worse, and also treatment options for Marfan syndrome. So I hope you can have a healthy and happy 2024. I'm here to take any questions if you have any about this topic.
Thank you so much. That was very informative. So we do have a few questions here that maybe you can answer. So the first one asks, does spinal fusion for scoliosis increase the risk of degeneration in the unfused vertebrae below?
That is a great question. It does to a certain degree, although not everybody gets degeneration. Everybody's connective tissues are different, and some are more prone to degeneration than others. So not knowing who's going to degenerate and not, we try to fuse as little as possible and try to avoid stressing the unfused parts too much. But in general, that is a risk for it, and it can be dealt with later if it happens by either physical therapy, extending the fusion, or doing spinal cord stimulation or some such maneuver.
Okay, great. Thank you. The second question is, what might cause the L4-S1 nerve root symptoms in the leg when imaging is normal?
The usual cause of those symptoms is a herniated disc or a spinal stenosis, in other words, pinching of the nerves by a bone spur. And if the imaging is normal and doesn't show those things, then it could be neurolectasia. It could just be a unique neuropathy that happens in Marfan patients, because Marfan patients seem to be prone to sometimes having nerve pain without an anatomic lesion, and that may be biochemically mediated. And sometimes it can be a degenerative disc, which can refer to the nerves in that area that exist.
Okay. So here's another question. If the rods work to help children with Marfan straighten their spine, why wouldn't it be used sooner or given as an option to all Marfan patients? They assume that it helps with back pain and therefore would help with the quality of life.
Rods have risks. Rods have risks of infection, risks of spinal fluid leakage, and risk of nerve damage. So we don't like to use them unless there's a clear-cut need that can't be answered any other way. If you have a developing scoliosis, we do like to fuse it as early as we can within reason. So it's not a risky procedure, but it can be done as safely as possible without heroics. But in general, rods are not an answer to most kinds of back pain. They're good if there's a deformity causing back pain. But if there's back pain without deformity, typically fusion with rods is not indicated.
Okay. Has there been any studies on the newer scoliosis surgery called anterior vertebral body tethering on individuals with Marfan syndrome?
That is a great question. Vertebral tethering is a way to control scoliosis without fusing at all. You're just putting a flexible tether in there and getting the vertebrae to hopefully grow straight. And in non-Marfan people, it works about 80% of the time, which is not great, but it certainly is worth something and has a certain role. In Marfan syndrome, the spine is just more stretchy and more elastic. It's hard to control with a limited fusion. And I've seen some failures of it, but I've also seen some successes. It's rare enough in Marfan syndrome that we don't have data on it. I would love to study that. So if anybody you know anybody who've had tethering, either good or bad results, please let me know so we can try to study the results and the best indications for this kind of surgery.
That's great. Thank you. What type of physiotherapy is recommended for scoliosis?
Physiotherapy does not control scoliosis as a deformity. It controls the pain associated with scoliosis. It may, in some cases, slow down the worsening that happens. And it's called scoliosis-specific exercises. It's done by a therapist who is expert in spinal body control and scoliosis itself, and proper breathing techniques and self-awareness. And typically it takes the form of stretching exercises, balance exercises, feedback exercises, where the person learns what muscles to turn on to control their curve. And it also goes by the name of Schroth physical therapy, after a German physiatrist who had the idea to use it several generations ago. Not every physical therapist who treats backs knows about this kind of therapy, so you have to shop around before you commit to somebody for that kind of treatment. But it does seem to have some promise for controlling pain and maybe for slowing down the worsening of the curve.
So this person is asking, is this operation recommended for older patients, say above 20 years old? I'm assuming they are talking about, the spinal fusion and the rods for scoliosis.
It's typically done in young teenagers, 14, 15, or 16, because that's when the curve usually develops and becomes significant. It's also true that the younger you are, the faster you heal and the less pain you're going to have, and the less risks and complications you're going to have. And most importantly, the less it interferes with the important milestones of your life, such as graduating college, getting a job and keeping it, and starting to raise a family. So in many ways, it's good to get it taken care of while you're young and can deal with all those things easily as possible. But it can also be done in any adult age, even 20, 30, 40-year-olds. Some 50-year-olds have had it done too without significant complications. So there's no fixed age barrier to doing it whenever it does present itself as a problem. But the younger you are, the easier it is to go through all those hurdles.
Okay. Can you go over a little bit in more detail the types of non-surgical treatment for scoliosis, and maybe when is it time to actually think about surgery then when non-surgical treatments don't work?
Non-surgical treatments include various kinds of bracing. The braces that we use are called Rigaud-Chanot braces, or sometimes spine cord braces, or other things that are flexible, and they're targeted to put pressure on the spine in the right places to straighten the curve and keep it from sagging and collapsing and getting worse. These are custom-made braces. They're not braces you can just go into a store and buy right then and there. You have to get it kind of computer modeled and computer printed from an image of your own particular curve. And there are many different varieties. Almost every city has different specialists who deal with it and make the braces in different ways. These are typically successful in helping pain and slowing down the rate of the curve, but they don't stop it as well as a non-Marfan person would experience. In addition, another non-surgical option is Schroth physical therapy, as we just mentioned, which is a specific body control feedback strategy to help turn on the right muscles and let you realize how to control your body and build up tolerance to doing so in scoliosis. Those are the main non-surgical treatments. And then there are many surgical treatments that we talked about, and those are much more invasive, and they're pretty big undertakings to go through. It usually requires a couple months out of school or a couple months out of work before we can get back to near what you were before.
Right. Okay, so there's another one. I am in my mid-30s and have some mild scoliosis and get frequent back pain. I'm a little concerned that it will get worse as I continue aging. Is it essentially too late for me to treat my scoliosis with back brace?
Back braces are typically used during the growth spurt of a teenager because that's a short and reasonable period of time that you can have a major influence on what's happening, which is the rapid worsening of your curve. So that's why we use it in kids of that age. In adults, if you hope to control it, you're basically talking about wearing it during the rest of your life for a long period of time. And through all the changes and things that you're undergoing as a decades long of adulthood. So it's reasonable to try if you're having pain and you would like to avoid surgery. I think it's reasonable to try, but you just realize that it's not something you can wear for a few months or a few years and then it will stay better. It has to be worn continuously as long as you're standing up against gravity, which I hope you are, or anything else that will cause the curve to worsen.
Okay, thank you. Osteoporosis. Do you see it in younger people than usual in Marfan syndrome patients? And if so, why?
Osteoporosis has a specific numerical definition, which is the bottom 2.5% of all the people with bone density problems. So it's a pretty strict and strong diagnosis to have. It typically our bone density tends to go down continuously as we age, and females faster than males because of menopause and lack of estrogen stimulation. So it tends to happen to females in the 60s through 80s and males in the 80s through 90s. In Marfan people, it happens more frequently, and especially at a younger age, as the questioner had intimated. The frequency of it in Marfan is not widely agreed upon, but it's probably about 20 to 30% of Marfan patients have osteoporosis. And why that happens is a bit of a mystery. It probably has to do with the old culprit TGF-beta binding, and how it affects the collagen matrix of your skeleton on which the calcium is laid down. Bone mineral density is basically just calcified tissue, and hopefully it's strong, organized calcified tissue. But in Marfan patients, the bone density tends to be a little less. It's not just a matter of simply taking more calcium in your diet or drinking more milk. You have to have a protein substrate or matrix that will absorb and allow the calcium to adhere to it and build on it in an organized fashion.
Okay, thank you. For osteoporosis, this patient has been recommended to do some weightlifting, but in Marfan syndrome, it is not recommended. What would you recommend? Do you recommend light weight-bearing exercises, or are there any other newer recommendations?
If you're concerned about osteoporosis, you should be followed by an endocrinologist or other bone health specialist. Sometimes a nephrologist will do that as well. And they can look at your whole risk profile, which often involves the eyes and the aorta, the main reasons we want to avoid impact. But osteoporosis doesn't require a lot of highly energetic endurance like events like weightlifting. It can be just repetitive, low yield cycling of walking, climbing stairs, any kind of repetitive medium intensity impact can help to build bone density. And so it doesn't usually have to be anything that's going to stress your heart. It could be just regular long distance walking or climbing stairs, or just trying to make sure you do more for yourself and not depend on others to do your daily chores.
Mm-hmm. No, that's great. Thank you. Can you talk a little bit about whether there's a connection between a CSF leak and cases of scoliosis?
CSF leaks usually don't happen by themselves without some kind of a provocation or an invasive intervention. So surgery can certainly lead to a CSF leak. It isn't something that we typically see in most scoliosis patients, but putting in hooks or doing anything around the dura in Marfan patients, that dura is very weak and it's more prone to just start leaking, even if we don't do anything drastic to it. If we just kind of brush by it with a hook or brush by it with any kind of a surgical instrument, it will sometimes start leaking. Not every Marfan patient has severe dural ectasia, but some do. Dural ectasia is often a result of scoliosis surgery. I would say in our study, we had about 20% of people who had a CSF leak, but to see it happening without surgery is only about a rare thing of about probably a few percent of Marfan patients will have a spontaneous CSF leak. And the symptoms that make you know you have it include sometimes a headache or just a fatigue or a pain in your arms and legs that is unexplained otherwise.
Okay. In the event of a spinal fluid leak, does it take patients with Marfan syndrome a longer time to heal as opposed to somebody who does not have a connective tissue disorder?
Unfortunately, as you can guess, the answer is yes. The main treatment is just recumbency. In other words, using gravity to prevent the pressure building up above the CSF hole or the leak point. And so there's less pressure above and less need to restrain a highly pressurized column of fluid. It does seem to take longer for them to heal as well. Oftentimes there's no surgical treatment for it because going in and sewing up the weak dura is just going to lead to more leaks in most cases. So we try to let the body seal it and just drain it off somewhere else by aspirating it or shunting it to another body part.
Okay. So for severe scoliosis in adults, is there any other way of managing scoliosis other than fusion? And what treatment would you recommend in adults?
There is that anterior scoliosis correction. There's also something called posterior dynamic distraction, which is a flexible rod that has flexible attachments to the screws above and below. So there is a little bit of give, not a lot of give, not a normal amount of give, but some give in this spinal instrumentation. So it's not a fusion and doesn't make the body go into an autofuse response. It's something that is still pretty new in the infancy of being tried in humans. We haven't seen anybody with Marfan syndrome who had that, but that's another option. And bracing, of course, is the other non-surgical option. Unfortunately, there's no medical intervention that's a pill, for instance, or an agent that you can give that changes the body's propensity to develop curve, because we don't really know that much about what causes the body to curve in some people and not in most. So there's unfortunately, there's not a really great magic bullet like we hoped we would when we were starting the genetic revolution.
Okay, thanks. So would an inversion table help with pain? Are Marfan patients advised against using an inversion table?
That's an interesting question. It seems like every year in the workshop, we get a question like that. And the answer is inversion tables can often help just to decrease the pressure and the stress on the back. And many people report that they help. And Marfan syndrome, it stands to reason that they will help as well. There's no contraindication to it as long as the cardiologist agrees and the ophthalmologist agrees. And I think they are not on record as saying that they would not support it. So I think it's a good thing to try. Another conservative thing that can help your pain. It probably doesn't help your curve too much, except in proportion to how many hours a day you can be in the inversion table.
Okay, thank you. So for preteens, at what degree of scoliosis would you recommend any type of treatment?
Well, I guess the only thing that is sometimes effective is a brace. And I would recommend that when the curve is about 15 degrees or so in a preteen with Marfan syndrome. Preteen being like 9, 10, 11, 12, just before they start to take off and have that growth spurt. That's the period of greatest concern. That's when you should watch them most carefully.
Okay, thank you. So does Marfan automatically mean a huge risk of arthritis when you age, or does it vary?
Not a huge risk, and I'll expand beyond the spine. There is a definite increased risk of hip arthritis in Marfan syndrome because of the deepened hip sockets called protrusio. About probably 10% of Marfan patients need hip replacements. And the knee replacements are much less commonly needed, but they are also an issue because the loose ligaments cause abnormal wear and tear on the knee joints. In the spine itself, back pain is often caused by various kinds of spinal arthritis. In other words, the wearing out of the normal disc shock absorbers between your vertebrae, or the wear on the joints in the back called the facet joints, which can cause bone spurs and form pressures on the nerve. So Marfan people are more likely to get those kinds of arthritic type symptoms at a younger age. And how to prevent it is basically just avoiding getting overweight, avoid getting damage to your ligaments by tearing your knees or anything else, and staying in good core muscle shape and maintaining a healthy body weight.
Okay, thank you. So many patients, parents of kids want to ignore scoliosis and not accept the precautions pushing children for sports. Do you think that is safe?
I think sports are an inevitable and important part of our culture. It's how we often relate to each other and channel our competitive and other comparative needs. So I think it's something we should not ignore as being too rash and something that's just frivolous. I think sports are often healthy in many ways psychologically. So I join many of the board experts in trying to see ways for kids to channel their energies into certain kinds of sports that are not extreme and highly risky for Marfan patients. Non-contact sports, especially, and non-impact sports, avoiding football and gymnastics, but thinking about individual things like swimming or running, especially in cycling, I think are good for Marfan patients. And I think that you should talk to your physician about what is your relative's most important individual needs and risks, and what kinds of sports are best for he or she. But try to keep them get them engaged in sports if they're at all interested, because I think it's a very healthy way to develop and socialize with others.
All right, thank you. We had one last question, but it is in Spanish and I cannot translate it right now. So if you would, the person who's asking the question in Spanish, if you can put that into marfan.org/ask, we can certainly get that answer to you back in Spanish. So I want to thank you, Paul, for hanging in there and doing this webinar for our membership. This was very informative and provided a lot of information for our families. I want to thank you and thank our participants for hanging in there during the delay. And I want to wish everybody a wonderful evening and a wonderful weekend. So take care, everyone.
Thank you. Thank you. Sorry I had to go to round two, but I really enjoy working with the Marfan community. Have a great weekend.
Thank you, Paul. Very much appreciated. Bye-bye.